Hey everybody, you are listening to The Poison Lab, and today we have another episode of Toxicologists vs. the Internet with an excellent guest, Dr. Joshua Trebach, a hilarious Twitter medical educator, a New York City emergency physician, and a soon-to-be freshly minted medical toxicologist. We have an absolute blast on this show, running through our toxic differentials with some fishy cases of poisoning, and diving into questions from the internet. We cover topics like, can medications become harmful after they expire? How exactly should you treat that headache with alcohol use? And how much THC is too much THC? It's a great episode, and I want to dive right in. But before we start, our standard disclaimers. We're going to be answering questions on the internet from people who may be trying to use drugs for the wrong reasons. Anyone using illicit drugs is exposing themselves to risks of potential contaminants, wide dose fluctuations, and toxicities of the drug itself. While this gives us a medium to explore toxicologic concepts, we are not advocating for anyone to use illicit drugs. If you are struggling with substance use, call 1-800-662-4357 to access the SAMHSA free helpline and get the care you deserve. Second, we're going to be talking about real fatalities, and while this allows us to discuss a lot of great learning points, some of these were intentional fatalities. If you or a loved one are struggling with thoughts of suicide, someone's there to listen. 1-800-273-8255 is the National Suicide Prevention Lifeline. Please call. Finally, even though we're going to be discussing medical management, treatment, and diagnosis, this podcast is intended for educational purposes only, and we are not providing medical advice. If you think you're being poisoned or you have a general healthcare question, call your primary care provider or reach out to your local poison center at 1-800-222-1222. Now, let's get on with the show. Hey everybody, you are listening to The Poison Lab, a show about poisoning from people who manage poisoning. I'm your host, clinical toxicologist and emergency medicine pharmacist Ryan, and today we have a very special episode of Toxicologists vs. the Internet with our guest, Dr. Joshua Trebach, MD, an emergency physician in New York City and a soon-to-be board-certified medical toxicologist in Iowa. Welcome to the show, Dr. Trebach.
Hey, thanks for having me. Pleasure to be here. How are you, man?
I'm good. How are you? Thank you for joining.
Yeah, of course. It's going to be a lot of fun.
I'll give a little bit of background on you for our listeners. Dr. Trebach finished his medical school and medical residency training at the Johns Hopkins Hospital, where he did his emergency medicine residency. He then went on to complete a 2-year medical toxicology fellowship to the New York City Poison Control Center. And we have basically a freshly to-be minted toxicologist on our hands on the show today, the most up to date on all topics.
Yeah. We just had our unofficial graduation like the other day, but I still have call left, so it feels weird. I don't know. Yeah, everyone says, "Do you graduate?" And I'm like, kind of. I mean, so I'm going cross country to Iowa. So
yeah, that's exciting.
I'm gonna be a Midwest boy.
You got the plaid on already.
So. Yeah, I know, right? I was like, we'll see. It's gonna be like a 20-hour car ride, and so getting a good playlist for that.
Is it music or is it audiobook?
It's currently just music. I just sing until I get tired, so it's probably not good when you're driving.
Well, thank you so much for joining. I really appreciate it.
Of course. Like I said, it's a long-time listener, big-time fan. Happy to be here.
Oh, well, thank you. I believe I actually first encountered you when you were doing so I'm the chair of the acute and intensive care section of this toxicology organization. We do a webinar every year, and you did an amazing job on assessing the QTC interval in a toxicology patient. And I remember you were talking about 2 different ways to assess the QTC interval in an overdose. And you made a reference to one was Team Edward and the other was Team Jacob, I believe.
Yeah, I don't think anyone remembers that. So
no. After I saw that, I was like, yeah, I need to bring them up. So.
I don't confirm or deny that statement. But yes, I remember that very clearly. It was one of one of my finer moments.
And you also have a wonderful and delightfully educational Twitter feed. I believe it is. What actually, can you, so I don't mess it up, can you give me your Twitter handle?
My Twitter handle is @J, the letter J, and then my last name Trebach. So @JTrebach.
Well, that was really easy. Okay.
Yeah, it's pretty intuitive. No, it's my name.
Yes. So you frequently post toxicology murder mysteries, which are really fun. It's kind of like what we're going to do today, where we kind of try to solve a case based off the clinical presentation. But yours have far funnier memes as well as scenarios that occur, I think. And there's many plane crashes involved. It's
it just fell into those. I'll say the memes are, the tox stuff is a lot of fun, and gone through a lot of training to learn how to do that. But the memes, no one teaches you how to do the memes. Those are challenging. You gotta find something that's relevant, something that fits. There's a lot of different memes out there. It's I don't know. I've gotten a lot of different experience in different realms, so it's been a lot of fun, and I've gotten good feedback too. So it's been a blast.
Absolutely. It's really, memes are kind of their own subspecialty.
Yeah,
and the medical meme fellowship hasn't come out yet.
Yeah, keep an eye out for it. I'll start a fellowship for that in the distant futures.
I think the near future. You'd be a great first director.
Well, thank you.
Thank you so much for joining the show and lending your freshly sharpened toxicology expertise. We are very excited to have you on. And for the listeners, as you know, in the Toxicologists versus the Internet episodes, it's a little bit different. There's no toxo here, and we're going to go through a couple segments. So the first segment, cases, where we both review interesting toxicology cases, reviewing the clinical findings, maybe some of the history of exposure, and then the other person will try to make an educated guess at what the potential exposure could be, with the goal being for us or for people to hear the differentials and maybe learn what common exposures look like. And then we have another segment called Toxicologists versus the Internet, where we answer questions from reddit.com/r/askdrugs. But before we get into that, Dr. Trebach, would you mind telling us why you chose to pursue a toxicology fellowship after all your many years already of extensive medical training? What is it that you enjoy about toxicology?
Yeah, that's a fantastic question. I find that with medical toxicology, it really falls into like three big categories. The first is it has a very strong public health component, which I very much enjoy. In emergency medicine and throughout residency, I got to see just the power that public health can have in treating our patients, not just in the emergency department, but also at a population-based level. So whether this is with things like naloxone or educating and teaching parents and caretakers how to store and safely keep track of medications and things like that. I find there's a lot of work that can be done just before patients even arrive to the emergency department. So from a public health standpoint, it's something I really appreciate. The second thing is that I've always been someone who liked pathophysiology. Even in med school, I found that understanding how a disease works or a drug works or how symptoms manifest really helped me memorize things a little bit better and made me understand. And I found that quite enjoyable. I found it a lot of fun. And so the world of toxicology, we are people who love pathophysiology, perhaps even too much. Sometimes the pathophysiology in the absence of any data whatsoever will drive our management of someone. And it's always fun to be able to say, oh, well, I'm pretty sure it's this receptor, so it would reason that ketamine would work, or, something like that. So it's a good time. And then lastly, as you kind of mentioned to or alluded to earlier with some of these puzzles, I do love puzzles and mysteries and figuring things out. And sometimes toxicology is a big whodunit. I've gotten consults before where people are like, look, we really don't know what's going on, but someone asked us, is this tox? And so we're going to ask you that. And it's funny, sometimes the question is like, hey, this person has this rash. Is this tox? I'm like, oh, it could be. I think the answer is always, it could be. But every now and then you
were they working with limes?
Yeah, exactly. Your people, infectious disease always gets a lot of the credit for taking those detailed histories, and they certainly do. I love my ID colleagues, but I find that we ask some very interesting questions as well. Like how often were you using these skin creams? What did the cream look like? What season was it? Where did you go? What country were you in?
Get it from Mexico.
Exactly. So for those three things, the public health, the pathophys, and the puzzles, it's quite a lot of fun. And the people are great too. It's a wonderful community. I feel like every toxicologist knows each other. It's a small world, surprisingly.
The 3 Ps: public health, pathophys, and puzzles.
Wow, look at that. There are 3 Ps. How about that?
If that puts a smile on your face, toxicology might be for you.
Yes.
I like that. I definitely hear the pathophysiology is a very commonly brought up component. I think everyone who finds their way into this really likes a mechanism. And that's kind of nice too. Sometimes in medicine, there's so much evidence and you have to do so much by evidence, but sometimes when there's not any evidence and all you have to run on is the pathophys, it's a little bit, not Wild West, but it's more freeing.
Yeah. Sometimes we have a case report thrown in there.
That's right. And then there's evidence. Thank you for sharing that.
Of course.
I think it's a sentiment echoed by many toxicologists. So, okay. Well, maybe we can just dive right into the show here. So the first segment is called, is where we're going to do some fatal overdoses, or potentially non-fatal, but severe overdoses. And these are generally sourced from the American Association of Poison Control Center fatality reports. These are real fatalities that poison centers were contacted about. And we certainly don't want to make light of any of the fatalities that occurred, but these are real patients that a clinician might encounter. And it's important for them to be able to understand what the presentation might look like in order for them to handle it. I will say, actually, in this episode, I have pulled a few just case reports of interesting exposures that weren't deaths that I thought might be relevant or interesting. So the only rules are you can't give away the poison, and you de-identify if there's an antidote that's only used for one thing, or like a very, very clear. You could give history, whatever you think is important.
Sure.
So would you like me to start and kind of give an example, or do you want to kick it off?
Oh, yeah. Let's have you give the case first. So I make sure I don't give too much when I do it.
Okay. All right. Well, here's the deal. I have 6 cases and I have randomized them. So
okay.
I felt like this would be perfect for someone who's like studying for their tox boards.
What have you done?
So they are a little more challenging, just so that they're less frequently seen.
Okay, this will be fun.
But I think it'll be good. I don't feel bad. So just pick a number 1 through 6 for me.
Let's do 2. And do you want me to choose 2 numbers?
No, 2 is, oh boy.
2. Oh God. Oh no, what is this like?
Okay, ready?
Yeah, let's do it.
Okay. 2 British medical students, a 23-year-old female and a 24-year-old male, were on rotation in the South Pacific Cook Islands. It was an elective. They shared a meal.
Okay.
And 12 hours later, developed nausea, vomiting, and this progressed to paresthesia of the mouth, hands and feet, myalgias, pruritus, and cold allodynia, where cold objects felt hot to the touch. They presented to the emergency department after the development of the neurologic symptoms, and they were given antihistamines. But in the duration of this case, their neurosymptoms persisted for about 4 weeks. And actually, the cold allodynia lasted about 10 weeks total.
Interesting.
They didn't die.
Love to hear
Their
that.
plane could have crashed on the Cook Islands.
Oh, gosh.
And the meal that they shared was
I don't want you to tell me the meal.
Okay, all right.
Well, I don't know. I feel like just hearing that, alone, it makes me feel good that 2 of them either are having identical strokes at the same time, or they probably, it seems less likely. Something that always crosses my mind to play the odds game. We're like, well, what are they with strokes? It's a little bit more unlikely. Just hearing 2 people on an island. You said Cook Islands, an island. I heard island.
Yeah. I didn't know where Cook Island was. I had to look it up.
Honestly, I'm not entirely sure. I have a guess, but island is kind of what I need to hear. I think eating something, which sounds like it might be some, given that they're on an island, maybe something that lives in the water, makes me think, there's a huge broad differential for the different types of, fish or shellfish, things that you can eat. But the temperature symptoms that you gave are super, buzzword might be too strong, but they make me think of certain conditions. The big two I think of when I hear about like temperature involvement or temperature reversal or this cold allodynia would be ciguatera, and then also neurotoxic shellfish poisoning. It's wild to me in fellowship that you learn about all these different things in the water that can do awful things, and it's just terrifying. And so if I had to put my money down, I would say this sounds like ciguatera just by the length of the symptoms that they lasted this long and that no one died. But I think there's a little bit more. I could expand that differential out a bit.
Well, given what I have for you, which isn't a lot, you just won your money. That would be ciguatera. That would be ciguatera. Yeah, I didn't even have to tell you it was a parrotfish.
Oh,
because if I had told you it was a shellfish, right? It would have narrowed it down.
Yeah.
Excellent.
Well, yeah, those are pretty interesting. I feel like I've never experienced those temperature symptoms before, but I can only imagine. I also feel like sometimes people describe like their teeth feel like they're falling out, or their teeth feel numb. Or loose teeth. Yeah, which again, it's a little bit scary.
It's terrifying the amount of toxins that come from the sea. That's kind of maybe a theme that I have here, but
oh god.
So yes, you were right on track. Ciguatera, and I think the key there being cold allodynia is some have described it as pathognomic for ciguatera, where your reversal of hot cold sensation.
Yeah,
I have some ciguatera fast facts.
Oh,
if you'd like any.
Love them.
So, for the listeners, ciguatera, it's actually one of the more common seafood related poisonings. I don't think it's the most. I think it's the most common finfish related poisoning. But so ciguatoxin activates sodium channels, causing an influx of iron. So it basically turns your sodium channels on. It's sort of like the monk's hood of the sea, although much less lethal, or the toxin of the sea.
Nice.
So it activates sodium channels, depolarizing cells, and that's kind of like the hand wave. It's a sodium channel related thing, and that's why you get nerve involvement. But the way that humans eat it is via biomagnification. So dinoflagellates in the Gambierdiscus genus, I'm sure I butchered that pronunciation, which grow on algae, they produce ciguatoxin precursors, and then herbivores eat the algae. They get those precursors, which then get converted into ciguatoxin, and then predator fish eat the herbivores. And they are eating multiple herbivores and all of the ciguatoxin that those herbivores ate, and they're concentrating it into that fish. And then we eat the predator fish that concentrated all the ciguatoxin from the herbivore fish into itself. So that's the biomagnification. This example was a parrotfish, but there are tons and tons of different fish that have been implicated in ciguatera: barracuda, eel, amberjack, sea bass, sturgeon, parrotfish have all sometimes been called out or have been associated with cases. I think like over 400 different species have been identified, but generally they inhabit like kind of low-lying shore areas or coral reefs where they can feed on these dinoflagellates that grow near coral generally, or algae. I mean, it's a reef areas are usually. So that's why we don't see a ton of this in the US, but there are cases that crop up and are reported throughout the United States, obviously more often in coastal areas and southern. So California, Florida, Hawaii has cases that are associated with it. It's kind of like esoteric out here, but in Cook Island apparently has the highest rate per capita of any island.
How about that?
I don't hear about really many deaths, but what's fascinating is that 10 weeks of cold allodynia. Oh my goodness.
Yeah.
So it seems to be persistent in the biologic system for some ways.
Yeah, I've heard that patients can go quite several months and just have some symptoms that continue to last. So it's not like some acute episode that you're just done with immediately.
Right. Unfortunately,
yeah.
Check your fish, I guess. I don't know. There's no test for it really. Although like some university probably has a test, but yeah.
I'm sure that it's a send out. You can't add it on.
So one of my favorite reasons for this was a case report that clearly 2 medical students wrote about themselves and published, and I loved it. I loved that
dedication.
That was good. I'm appreciating.
Yeah, I
So
appreciate
excellent
that.
job. And they didn't die. So happy ending.
Yeah, a happy ending. Yeah.
Oh, you mentioned also, did you say neurotoxic?
Mm-hmm.
So, yeah. So there are many other potential sodium modulating toxins out there, like brevetoxin, saxitoxin, all those things. And so whether you eat a shellfish versus a fish kind of narrows your differential a little bit,
Yeah.
because you have paralytic, neurotoxic, and amnestic shellfish poison. There's a whole bunch of wild ones. So.
Yeah.
Okay. Well, that was the case. You nailed it.
Oh, yeah. Those are fun. The sea. Be afraid of the ocean. Be afraid of the
Yes.
water. Terrifying things live
Made
inside.
to not help us live.
No, it's agreed.
Well, not in
Agreed.
it. Outside
Yeah.
of it.
Good toxicology, though. Very good toxicology in the ocean.
All right. You got one for me?
Yeah, I do. Let me pull this up. So this is a 16-year-old female who intentionally ingested a substance they ordered offline.
Uh-oh. Wait, offline, like they went
Or
to
excuse me, it was online, but they got it off online. Well, what is the actual correct way to say that? I don't know.
I don't know.
They don't teach us that in fellowship, so
I think both are okay. Or just being,
she
a carbon.
she purchased it online.
Perfect. Okay.
So unfortunately, there's very, very limited history because the patient just arrived unresponsive and cyanotic.
Oh no.
Hypotensive. O2 sat was just persistently in the 70s.
Mm-hmm.
And they started to send. They immediately sent their labs. Noticed that.
All right. When did they give the methylene blue?
Yeah. I didn't even tell you what the met hemoglobin was. They did get a met hemoglobin that came back at greater than 30%.
So my guess for the differential here, I mean, you have a rapidly, well, actually, I don't know if it was rapid, but you have an unconscious cyanotic patient, particularly with pulse ox readings in the 70% range.
Yeah.
And, for that, with the pulse ox reading, I'm going to think this is probably an ingestion of a nitrite salt leading to fatal methemoglobinemia. But you could also think, common things being common without the methemoglobin level, an opioid overdose certainly fits this as well. You have a cyanotic person and they're unresponsive. But you said they bought it on the internet.
Yes.
And people do buy synthetic opioids on the internet. But given the history, I'm thinking this is a little more nefarious. Cyanide, right? The cyanosis is right in the term. Wouldn't necessarily affect your pulse ox. In fact, usually they have, bright red blood and they're highly oxygenated because they can't use it. And then pulse ox interference is sort of special for methemoglobin inducers because pulse oximeters just shine a wavelength of light at your hemoglobin. And depending on the oxygen saturation of your hemoglobin, your iron is in a different conformational state. So depending on that conformation, it shines or reflects a different wavelength back at the pulse ox. And that tells us how much oxygen is attached to your hemoglobin. And when you have methemoglobin and your iron is oxidized from ferrous to ferric iron, you reflect a different wavelength back. So it interferes with the pulse oximeter. At really high levels, it tends to just show 85%. So for that reason, when I think of like pulse ox interference, it kind of dings methemoglobinemia or low pulse ox. But you couldn't have that with other things like hypoxia, obviously. But this is, unfortunately, it sounds to me like a case of the disturbing trend of increase in suicide by ingestion of nitrite salt on the, which people read about on the internet.
Well, you're exactly right. This was, this is the sodium nitrate powder.
And then those nitrites will oxidize the iron in your blood from Fe2 plus, making it Fe3 plus and unable to really carry oxygen well. From ferrous to ferric iron. I always remember ferric is the 3 plus because Rick is really mean and he won't wait. Yeah. So he throws himself onto the 2-seater on the Ferris wheel. That's
a lot. That's a lot.
It's a lot. But the weirder it is, usually the better.
Yeah, that's true. That's true. And
do you want to go through the rest of the case so we can hear the presentation?
Yes. The patient is quite ill. They're hypotensive. Their GCS is 3. They're tachycardic to 130. The initial labs, it seems to show like a pH of 6.81. Obviously, very, very bad. It sounds like that hospital didn't actually have methylene blue. They had to get it from a nearby hospital. which is interesting because I feel like there's certain antidotes that all hospitals should have. And so I'm not sure if this was they didn't stock it or if they ran out from another patient. I'm not sure, but it sounds like they had to get methylene blue from a nearby hospital. And then unfortunately, the patient did code, despite even receiving the methylene blue, continued to have persistent methemoglobins greater than 30%, and ultimately died about 2 hours after arrival to the emergency department.
Oh, it's very quick.
Yeah. I unfortunately, we've just been seeing a large uptick in the amount of these cases, and it's truly devastating because it's exactly as you said. You can just order this stuff offline. It is used for, I believe the powder is used for like curing meats.
Yeah.
And so if there's two like different camps of like reviews or discussions around this product, it's people who are using it for its intended purpose, and then people who are using it as a way to commit suicide. And, Googling this or looking this up on the internet, you'll find people telling you how to use this if you want to harm yourself. And I feel like it's a little bit dangerous that something so scary can just be purchased off Amazon. I don't know. Can you get it delivered with Prime? I don't know. This is some scary stuff.
I actually, after the first case of this that I ever saw, it was a methemoglobin of like 80%. I actually bought 2 pounds of it off Prime just to see what it looked like. And it was like $15. But it's a curing salt. Yeah, it's crazy.
Yeah.
So maybe the best name for a case series I've ever heard. A past guest of our show and the associate medical director of our poison center, Dr. Jillian Theobald. She wrote, it's called Beef Jerky Blues. And it's because it's all these people using nitrites to make beef jerky as a curing salt and then getting methemoglobinemia.
Yeah, I think something that stood out to me about this case was that it's a terrifying situation to think you have a patient who's got a tremendously high methemoglobin level, and then if you don't have methylene blue on hand, what are you going to do? And even heroic options that have been theoretically discussed, like exchange transfusion or something, like I don't know if you're going to be able to exchange transfuse your hypotensive unstable patient effectively, but that's just a situation I would never really want to be in. But even as we saw, though, people can get methylene blue and still unfortunately die just because that sounds like that methemoglobin level can be just so darn high.
It was interesting that this hospital could only measure greater than 30%. Good. I don't know. I'm used to seeing the number.
Yeah, I feel like something that I've seen in just all these cases in fellowship, and Tox fellowship is great. You get hammered with so many cases day after day after day. Something that I've seen is that some places will be like, oh, this Tylenol concentration is like greater than 50, and I'm like, we need more than that. Like, I'm like, come on. Like, and then other times be like, oh, like less than 200. And I'm like, can we, like, I don't know. I think what I've learned is that it's either the way the lab reports it, because this is how, and other times it's been the lab can't give a number. Like one time I spoke with someone in the lab and they were like, oh, I can't type in a physical number. I have to write it in the comments. And I was like, oh, this is so strange. I feel like this could be dangerous because 31% versus 90% are dramatically different. Right. And although both are not ideal, one does spark less joy than the other.
It does spark much less joy. And the methylene blue. So for the listeners, there is a guideline. I believe Richard Dart is the first author, but it's about antidote stocking in emergency departments. And it has recommendations for what should be available within 1 hour, what should be immediately available. So if you work at a hospital where there's no methylene blue, maybe check that guideline. I'm betting they had methylene blue, but Ortho wanted to do a bunch of joint challenges to see. Our Ortho loves injecting methylene blue into joints in case.
Yeah. It's a good point. I feel like
they drained it.
You always got to know who has got the backup supplies of your antidotes, right? Like, the ophthalmologist will have atropine if you need it. Maybe the ortho people have methylene blue. I like that.
Yeah. All right. Well, excellent. Thank you very much for that case. Let's trudge on to the next case. So
let's do 5.
5. Oh.
I don't like your responses to whatever I pick a number.
It's fun, and I like this one. Okay. Are you ready?
I'm ready. Go for it.
A healthy 48-year-old woman and co-author of this paper developed. So they called it out right away in the abstract of this.
Okay, that's
You
fine.
know she didn't die. That's good. So a healthy 48-year-old woman and co-author of this paper developed palpitations, tachycardia, and hypotension 10 minutes after eating a peppery tuna steak dinner.
Ooh.
She subsequently developed numbness of her face, severe flushing, conjunctival erythema, abdominal pain, nausea, vomiting, diarrhea, headache, and chest pain, prompting her to seek emergency care. In the emergency department, her ECG actually revealed tachycardia with ST depression, and her hypotension was refractory to fluid resuscitation, requiring phenylephrine to correct it. The patient was started on famotidine and managed to be weaned off their vasopressors and was discharged from the hospital 43 hours after their initial presentation with a normal ECG.
Oh, that's nice. Wonderful.
So, you got a patient, they eat a peppery tuna steak, become hypotensive, refractory to fluid, requiring vasopressors. They have some signs of ischemia on ECG. They are flushed, conjunctivally injected.
Yeah, I feel like it's funny. I've definitely eaten peppery things before, and this has crossed my mind. I'm like, oh gosh, is this it? Or did I just put too much pepper on this? But the saying the peppery taste usually makes me think of scombroid toxicity. There's a lot of there's in the world of foodborne stuff. I don't know if your trend here is cases where people didn't die, or cases where people ate something and didn't die, or cases where people were the patients and then wrote about it.
That's my trend right now. Yeah. This is where it was a fish and you wrote about yourself.
I like it. Okay. Yeah. So scrumboid, usually people, the story is they're eating some sort of fish that's been bacterially, there's bacteria on the fish or something. It's like the fish was warm or left out, and they eat it. They know this peppery taste. Their best friend who also ate it says, yeah, I agree. And then symptoms exactly as you said. I don't think I've ever seen someone with ischemia though on their EKG from it.
I'm betting it was just from the florid hypotension. I mean,
yeah, probably hypotension and rate related in quotes. Yeah, that's what we always say.
Yeah, so that is unusual. That's, I think, why this was a case report.
Yeah, it's very interesting.
So for the listeners, scombroid is basically histamine poisoning. You've all heard of antihistamines, which histamine is an inflammatory regulator. When you release it, you vasodilate so that your immune cells can get into your bloodstream and attack whatever non-self that you find. But fish have the amino acid histidine in their body. And if they're inappropriately stored, so greater than 40 degrees Celsius, the bacteria that are natural to the fish will metabolize the histidine via histidine decarboxylase into histamine. So you basically eat an allergy as a fish. And it leads to erythema, irritation. So you use conjunctival injection, it's just red eyes, vasodilation, and we'll see flushing. And this patient had a very severe case where they, vasodilated so much they became hypotensive. The fish that are implicated in this are fish in the Scombridae family, unsurprisingly, which are fish that have a higher level of histidine sort of at baseline. So they're more likely to have kind of a toxic level of histamine being produced if they're inappropriately stored. So these are fish like tuna, mackerel, marlin. There's a lot of fish that people generally eat. And it's okay because it's really a storage issue that leads to this. I kind of brought this one up because here in Wisconsin, people are transporting fish 3 days on land into Wisconsin. So we risk scombroid a little bit if it's inappropriately stored, but we don't see a lot of the other, shellfish. Although we do have some harmful algal blooms here sometimes, but people don't usually go swimming in that. So I thought it was a good case.
Eating an allergy. It's a great way to describe it. It sounds terrifying also, but yeah, I've seen a few cases of these. Again, it's like, I think most of the times I've had patients, they've done quite well. Just, give your supportive care and your antihistamines. And that's an easy management one to remember.
It's the antidote is in the name. Right? I think my theme here, just as an aside, my theme here has been people who wrote case reports about themselves, because I recently I succeeded in one journal. I failed in another one. I actually just got accepted for publication, a case report I wrote about myself.
Oh gosh, congratulations.
Yeah, well, it got denied because it was a single author case report written about themselves. I can understand that. I added a second author on to increase its objectivity. But then I submitted it to NACCT, and even though the comments were really good, they were like, "Oh, sorry, it doesn't meet enough rigor." But basically, I spilled like 500 micrograms of fentanyl on my skin, and I was like, "Hey, everyone's freaking out right now about touching skin and occupational stuff," and I was like, "This is actually confirmed fentanyl that I did fine," and I had a medical exam afterwards. But it did get accepted to pre-hospital disaster medicine, so I was excited about that.
Well, I think that's a great case, because you're right. There's a lot of misinformation about there of someone having fentanyl in their shoe 3 states across, and then you hear about it on the phone, and then suddenly you need naloxone.
Yes, exactly. So there is a little bit of, I think, a malaligned risk perception of dermal exposure to fentanyl, and you need good confirmed exposures in order to combat that misinformation.
Is that a line from the case report?
It's something. But I just remember, so when I was submitting the letter when I was like sending my letter that you send in, whatever, to the editor, that process, I was just like, there have been well-established precedents of people writing about personal experiences, and I had to cite the Nobel Prize winning study where a guy drank H. pylori and gave himself.
Oh yes, that's a great one. Everyone.
Yeah, I was like, look, someone can win a Nobel Prize about this. I should be able to.
Yeah, I support you. Oh, cool. I'll be on the lookout for it.
I thank you. We'll see if it actually makes it through. But anyway, so I was bringing them into my personal experiences here. But all right, should we jump on to another case? You got another one?
Yes. I have a great one for you that I'm excited for. Well, I think when I was reading the reports, I was interested to see this one listed as this is a fatality, but I was very interested. I was like, it's interesting. So when I read it, I was like, So I'll give you the case. It's a 63-year-old female comes to the ED 12 hours after consuming a weight loss product. She was told they were a special type of nuts, and that she was supposed to mix one in some tea, and then instead she ate 5 of them, and then came to the ED. She was bradycardic and having nausea, vomiting, and her potassium was 7.3. And she, her DIG was negative. EKG just showed some slow AFib.
Oh, DIG negative. So you bring up bradycardia, hyperkalemia, and obviously, what am I thinking? Well, digoxin, right? Because DIG is a sodium potassium ATPase inhibitor. It raises our resting membrane potential, allowing the heart to depolarize easier. It also causes easier depolarization of the vagus nerve, leading to bradycardia and reduced heart rate because you have increased stroke volume. So the body kind of auto-regulates and reduces your heart rate to maintain cardiac output. So we kind of pathonomically can see bradycardia, and because we're inhibiting potassium from being pumped into the cell, we see hyperkalemia. And that would match right here. But why would we have a negative DIG level? So what else could cause hyperkalemia? Okay, obviously there's some organic causes. Maybe she has renal injury, bradycardia, hyperkalemia. It sounds like adrenal insufficiency, but we're here talking about tox. I'll give you all full disclosure here. I know exactly what this is because I know the person who wrote this case report.
Oh, wait, really? That's not fair.
True. He is also a past guest of the Poison Lab, Dr. Justin Corcoran. And this would be a dietary supplement for weight loss. So the dietary supplement was supposed to be is this Delia, I think.
Yeah, they don't list that part, but it is some sort of.
It's supposed to be candle nut.
Candle nuts, yeah.
Oleander?
Yeah, it was yellow oleander. Yep.
Yeah. So this is one of our cardiac glycoside containing plants, yellow oleander. Interestingly, I think it is also one of the only cardiac glycosides, one of the only prospective randomized trials in all of toxicology there's only like, I don't know, maybe 10 of them, is using multi-dose activated charcoal for yellow oleander in order to reduce, because there's some enterohepatic recirculation, so you can give a bunch of charcoal over time to bind it from the gut as it's being recirculated. So, but it contains a digitalis-like compound, same mechanism, but might not be detected by the lab. This person get like 20 vials of Digibine.
They didn't say how much they got, but yeah, that's, I believe, actually for yellow oleander. I think that's what one of the case reports suggests. It's like 20 vials.
Right.
It's obviously
you have no
a lot,
idea.
Yeah, you have no idea. You just give it till they.
Until they're better. Hopefully.
Yeah. Hopefully. Yeah.
And then you give them another 20 vials. That doesn't.
Yeah.
A lot of things out there with cardiac glycosides in them. Many plants would include the oleanders. We have foxglove, which is the very pretty one that everybody knows with the big bells. Lily of the valley. And then my personal favorite is the bufadiene toad. Contains
it's a great one. It's a great one.
Bufotoxins, which have cardiac glycoside activity. So you can find them in many areas. But what was interesting here is the whole weight loss. It was supposed to be a different herbal product. No surprise.
Yeah.
Herbal supplier lied to you. And
yeah, it's, that it's very terrifying. The whole world of these non-really FDA regulated products. I've definitely had cases just in fellowship where someone says they were taking something and we're like, that doesn't sound right. And then we test it and we're like, oh, that's because it's not what they said it was. And, these things, these preparations, these herbal supplements and things they sell aren't really held to the same level of scrutiny that your Keflex is, right? So it's not the same playing field, and it can be a little bit dangerous. I mean, I find it absolutely terrifying that someone had surprise yellow oleander. I mean, this is something people take to purposely try and commit suicide, and this person took it, what it sounds like, unintentionally for a weight loss.
Yeah, that's just wild. Yeah. That's unfortunate. I wonder what happened to the manufacturer. Probably nothing. I doubt it. Might not have even been in the US. I don't know how you even. It's an interesting landscape.
Yeah, very interesting and very sad.
Well, excellent. A great reminder to be very careful about what you're taking OTC. There are some companies out there that do third-party verification. So if you are someone who's going to take something dietary or herbal, please make sure somebody's looked at it to make sure it is what they say it is, because generally speaking, nobody's regulating that. Okay. Well, we're going to do another case, or we can go on to questions. What's your feeling?
I found some cool questions that I think are fun to talk about. I think just because I don't know, I brought up two deaths and it was a little depressing, so maybe we can pivot into something less depressing.
All right, absolutely. Okay, so now we're going to move on to our Toxicologists versus the Internet segment, where we'll discuss some of the questions posted on reddit.com/r/askdrugs, and we will consider sort of the things that we would think about if there was a consult about somebody asking these questions from a health and toxicologic perspective. So if you want to kick it off, I can do my best to try to answer.
Sure. Well, so I have a couple that I found, but the two that I think are most interesting, we'll start with, I didn't write down the username. I feel like I should have, because that would have been fun. But someone had asked when I was looking on Reddit, different experiences that they and their partner were experiencing when taking codeine, and we're curious why that is, and how they are about the same age, and how can the drug affect them differently. And it's strange to me because I'm reading the comments and I'm like, oh, I think I know the answer to this. And I'm like, I see it in the other comments. I'm like, well, that's obviously wrong. So
I promise it's better to stay.
Yeah, I just stay off.
Unless you think there's imminent risk to health.
Exactly my thoughts. So I was like, no, I'm gonna leave this one alone. But yeah, I thought that was very interesting, and that was a good question for a toxicology fellow, I think, or someone with a fledgling interest.
Absolutely. So there is probably a very clear reason, and it has to do with CYP2D6 polymorphism. So codeine, you could almost think of it as a prodrug. So I always teach all my learners, any opioid with a C gets metabolized to an opioid with an M via the enzyme system CYP2D6. So for instance, codeine goes to morphine, hydrocodone goes to hydromorphone, oxycodone goes to oxymorphone, all via the enzyme CYP2D6. And for those, CYP is just cytochrome P450. It's an enzyme that our body uses part of the first step of drug metabolism. It makes the drug more able to have another molecule attached to it that makes it really water soluble so you can pee it out. CYP2D6 is one of the most genetically variable CYP enzymes. So if the actual parent compound being codeine is actually a weak mu agonist, which it is, then if you're a weak CYP2D6 metabolizer genetically, you won't get a very strong effect from the opioid because you're not making a lot of morphine. And that's really where most people get their opioid-like analgesia. One of the reasons why I don't particularly think it's a good analgesic, it's similar to the tramadol problem.
Preach.
There are some genes also that have been identified with differential expression of mu opioid receptors, which could play a role in people having different experiences, but it's less fun to talk about. Was one of them saying that they had a really extreme effect versus?
I couldn't really tell too much from the stem, but it just seemed like one person was getting the desired euphoric effects and the other person was not. And I was also wondering, in addition to the genetic polymorphisms, I was like, well, I wonder if are they on any other prescribed medications that interact with CYP2D6, right? Like if you're, we know historically people combine drugs to work with or against their CYP enzymes to give them desired effects. There's a lot of history there. And
do that all the time pharmaceutically. We use boosters. In the new drug Paxlovid, there's a CYP inhibitor to boost it.
Yeah, it's really interesting. And I think something that I always wondered in the world of toxicology is, hey, like if someone took a toxic drug that's metabolized or, that gets broken down by CYP, can we give them something that speeds up that metabolism? Unfortunately, it seems like, I don't know if that's really panned out too well. It seems like it takes a little bit to ramp up your CYP. It's not like something that happens like a light switch, but a very potential source of scientific exploration in the future. I don't know.
For the brodifacoum compounds, which last years, whatever it is, months. Super warfarin. They're CYP2C, I think it's 2C9 or it's 19. It's the same one that I think warfarin undergoes. And I know I've read a case report of giving somebody phenobarbital chronically to rev up their CYP enzyme so they can metabolize their brodifacoum. So that's exactly what you're.
Yeah, that's cool. That makes sense for drugs that last a long time like that, right?
Yeah.
Very, very interesting. And so, when I read this question, I was like, y'all need some genetic testing for your CYP enzymes and then maybe some med rec. But I didn't comment. I just made me think about I got very introspective and I wondered about my own CYP enzymes. And I was like, I wonder what my 2D6 is up to. Like,
I think if you do the 23andMe or like one of those genetic,
they'll tell you.
I think they give you your CYP profile. I don't know if it's always phenotypically the same as what you show.
But do I want to know? I don't know. Like, I just assume everything's going great down there, but like maybe
history is the spice of life, Yeah.
That was a good question.
I applaud you on withholding your answer from the.
I did. I let that one go.
I have one that we can jump into here.
Yeah, let's do it.
This one made me laugh a lot, so we're gonna do this one.
Let's do it.
Here's the question. I'm gonna try not to laugh. Okay. The question is, should I take these 600 milligram edibles? ? And I'll read you the full text here. It says, so I bought some 600 milligram Jolly Rancher edibles, and I've never done edibles before in my life. My friend who smokes hella weed took 300 milligrams, and he was high for 5 hours. Unlike him, I don't do weed. So I wanted some advice on how to take them or if I should take them at all.
Oh my goodness. It's a lot to put in a Jolly Rancher.
It's a lot.
That's a lot. Like the bag or just a single Jolly Rancher?
From the context I'm getting from this, I think it's the Jolly Rancher.
I don't, that's a lot. Like, I think when we're teaching people about these different cannabinoid containing products, aside from all the carcinogens that come with smoking something, when people are smoking a joint, for example, they can stop when they get their desired effects, right? However, if you were to like eat a 600 like milligrams of something and you just like chomp that up, like this isn't like suck on the Jolly Rancher and spit it out when you're like good to go. Like that's where people run into trouble. And I feel like I've been seeing a lot more people having a bad time after taking large quantities of like THC, usually from edibles. It's not like someone smokes the joint and can't stop, and then they like, it's usually like someone takes too much. And so
the joint is self-titrating, right?
yeah, it's exactly, it titrates itself, but you just get this bolus of THC and overshoot. And for those who are not familiar with dosages of THC, 600 is quite a lot. I think I've seen a whole bag contain like of gummies contain a total of like 300, and you're supposed to eat one or something like that.
5 to 10 milligrams is like the dosage unit that they require you parse it out into and like leave it.
Or they'll sell a cookie that is like 50 and you're supposed to eat like a quarter of it or something like that, right? Like I've seen a lot of those things, and the most terrifying thing about this is if it's in a candy form, if a child were to get into that, because I think this is my soapbox a little bit, but I feel like the whole pot is very, very safe and everyone does fine with it is for the adult population. But in the pediatric world, I've had patients get intubated. I've had patients get stroke workups. I've had patients get sedated, intubated, get an MRI, have all this stuff done because kids just seem to have a lot more clinical symptoms, and not just like scary, like altered mental status, but even things like apnea and cyanosis and poor tone and some scary, scary things. So
and that quote was before the era of hyper concentrated, hyper potent products that are now just out there. It was a different world. That was in the 70s. Everyone's like 6% THC marijuana. And now, with the advent of genetic, selection and hyper concentration, you have a, 100% THC and like all dabs, shard, all this stuff that's, it's a whole other world.
Yeah. So I think if that person, unless have been escalating their THC intake to reach that point of comfort with that level, I think they're in for quite a bad time. I'm glad they asked at least before trying to take, and hopefully the Redditors were supportive of not doing that. But
I do have some of their responses.
Oh God.
From this person, they say, "What? Dude, shoot for 5 milligrams. I use edibles and smoke weed, and 5 to 10 gets me high AF, dude. Stay away from anything above 15. Another person said, legal states do be wildin'.
They do be.
I just thought this was a great question because this is the person who goes to the emergency department.
Oh, absolutely.
It's exactly as you said. People aren't familiar with the pharmacokinetics of now what is widely available edible THC products. So they think they'll experience something. First off, they don't know how to estimate their dose.
Right.
And they take 600 milligrams, which is 120 times the recommended dose for someone who's never taken that, per the Redditors at least. And then, and what frequently happens is people will take something, it needs to become absorbed, sometimes metabolized before you really feel the effects, or they had a meal, so it's delayed, and then they continue to take more. And then we see people, because it's not like people using inhalational products where it's right away. So they end up overdosing themselves, and then causing panic attacks and whatever, ending up in the ED.
And then I think, we're focusing on the content, which is quite a lot. 600 is quite a lot. But in addition to that, it's just having these things look like candy or food or anything delicious, right? I mean, like, does 600 milligrams of THC need to be in a like handheld piece of candy? Absolutely not, right? I mean, like, this is my toxicology soapbox, and I apologize, but it's just all it is a setup for people to get hurt. I mean, like, even would it be that bad to put it in something that is shaped like a pill or something that's not candy? Because I've treated patients who did not intend to get high, or like I was cleaning my child's room and had a starburst, and it wasn't a Starburst, and you're only supposed to take half of it or something like that, right?
How do you make a cookie that you're only supposed to eat a quarter of the nobody's going to inherently know eat a quarter of a cookie.
Yeah, good luck with that. I can't, when I save like some pizza for later, it's like 10 minutes later. Like I don't, so I don't know. I know there is some legislation that's been introduced, and different states have different approaches, but not just candies, but like they'll have these things that look like Oreos, or things that look and taste good. And I get it, and it's a lot of trouble when I've seen some of these products have different languages on them too, and so you may think that a bag that looks like some sour candy and you can't read it is probably sour candy, but who knows how much THC it has. And a handful, no one eats, like if you buy a bag of gummy worms, you're not going to eat a worm and then call it a day, right?
I just want one worm today, guys.
Yeah, you're like, look, it's been a day. I just need one sour worm, one worm. Like, no, you're gonna be like me. You're gonna be a mess. You're gonna eat a bazillion of them, and then if these all contain THC, you're gonna wind up in the emergency department. And yeah, definitely have treated these patients too. Like, so I digress. Thank you for indulging.
I understand. Well, really, what I find interesting, because Wisconsin, it's all illegal still, but Delta 8 everywhere now.
Oh yeah.
Huge. In same problem. They're all gummies, and there's Delta 8 gummies that are 1,000 milligrams, and it just zonks. I mean, people are out from it. So pretty crazy. But I'm sure we have a bit of a unique vantage point. But people, lock up your stuff. Keep it away from kids. It looks like candy. All right.
Yeah.
Do you have another one?
Yeah. So this actually came to me on Twitter, and I thought it was an interesting question. I saw people talking about this in another thread, and I just thought it was very interesting. There's probably some history here that I'm not an expert on, but asked, if I have taken an expired drug, do I need to go to the emergency department? Or like, which drugs when they expire are bad? And I think that was an interesting question, because I think I definitely, even during med school, I remember like finding old acetaminophen in my bathroom, and I was like, oh, can't take this, right? And like I guess we just never learned that, or never were taught about that. And I don't know where this necessarily came from. I know that the FDA is big on like not taking expired meds for possible lack of like potency, I think is the biggest thing we worry about. But I feel like that's just like a common fear and concern that people have, is like, oh, this NyQuil is expired. Am I going to blow up if I take it or whatnot? So I don't know. Have you heard that before?
People definitely have questions about it. And let me set the record straight right here. If you take any expired drug, it's full of cyanide, and you're not going to.
No.
That is a joke, as I assume most of our listeners would know. Yeah, mainly. And actually, this comes into play a huge amount in hospitals with drug shortages.
Yeah.
For instance, physostigmine was expired. So the FDA looked at a couple batches of it, did some more testing, and guess what? It's all still there. It still works fine. So when you look at a drug expiration, the expiration is actually when 90% of the drug is still present and effective. That's what they call the shelf life, and that's what the FDA determines is the expiration date. Many drugs can actually go on well beyond that. I know there was a study of naloxone that was kept on an ambulance in the 1980s, and they found that when they tested it, it still had all of the same potency. It was all still able to be used. So we end up using a fair amount of expired drugs. It certainly depends on how it's stored. A lyophilized powder, it's probably going to be more stable than something that's been in solution and getting exposed to light. And I also think when they do the testing of these expired drugs, they don't necessarily look at like, what did it turn into? They kind of look more like, hey, how much of the active product is still in here?
Yeah.
I don't know of any drugs that expired as something worse than what they were, except actually, I do think naloxone has a degradation product that is a mild opioid agonist, since it's an oxymorphone derivative, but you still have so much naloxone in there.
Yeah.
And also that's not, it's kind of a unique thing. Most drugs, they're just less potent. I don't know of anything that actually goes like bad.
I know historically there were cases of and I actually had we chatted about this one day on rounds at work, but there were some cases many years ago about different tetracyclines causing Fanconi syndrome or something like that. But I've never seen, and I don't know if this was just, I'll have to pull those case reports, but I don't get it. And I think that is not true anymore. Like, I don't know if that's still a concern today. I don't believe so. I think the biggest thing that would worry me, honestly, is that if someone is taking an expired immunosuppressive medication, right?
Mm-hmm.
Or maybe
anti-epileptic or something.
Exactly, right? Like, I don't want you to take your expired anti-epileptic and go drive a car, right? Not wise. But like, if you're taking an expired, for the formal record, I don't encourage anyone to take expired medications. However, if you were to take an expired Tylenol, I don't think I would care much. But I think it should be noted, though, that like with these expired medications, that doesn't mean they're always safe, in that, like, if you have an expired medication that's been under your fridge for 4 years and you find it inside of a dead cockroach, that doesn't mean it's safe to take, right? I think you should throw it away. Yeah. But like,
in the perfect world.
Yeah, assuming properly stored medications, right? Not
right.
covered in something, but in general.
Well, you bring up a good point about proper storage too. So for one thing, I will go on the record and say my dad carries expired EpiPens, and I just, if that's what he's got, then use it. Yeah. All right. Yeah. But obviously I want him to have expired or non-expired stuff, but it's life-saving. It's all you got. You got to use it. But I also think you are right about the tetracyclines, because when you asked the question, there was like a weird, subconscious thought of doxycycline in my brain. Right. I didn't bring it up because I don't remember anything about it. It was just dinging, so that associated somehow. So I'll have to look into the tetracyclines, because I bet you that's correct, or at least there was old cases of it.
I think it's an old case or two.
But the other thing that a lot of people don't realize, especially with more extremes of weather, is like drug excursions. Some drugs aren't that great with that. So if you leave your EpiPen in your car and you live in the South, it's 110 degrees every day, and you're basically boiling your EpiPen every day, it's not necessarily going to maintain its potency as long as if you were storing it at room temperature. So, we ran into this problem a lot with insulin when I worked in community pharmacy and we were dispensing insulin. People had a long drive. They're always worried about how long can it be in the car?
Yeah.
Generally a couple of hours of excursions aren't a big deal, and drug manufacturers will have data on this if you call them. But it's not a good idea to just leave things, under the fridge or in a car.
Yeah, exactly. It's tough because you're right. When these drugs are made, they're not like, okay, so before we put it on the shelves, let's see how long we can drive with it before, right? Like the common things we want to know the answers to are like, oh, like what if you took a shower and then the shower steamed up, but the bottle was open and you left it in there. Like, we don't know the answers to these questions. And I'm sure that it can come into play a little bit, but in general, it's like loss of potency is the biggest thing we worry about. And I think, it's always fun to see, when people do these reports on like atropine from prior world wars, and you're like, oh, this still works, right? And so it's good to know. So yes, if I was in a life or death situation and a potential antidote was expired, I would take it, assuming it was properly stored and not under my fridge.
Correct. The last great frontier in medicine, putting pills into the shower.
Yeah. Yes.
Excellent. Well, great. That's a great question. It's something that, we can only guess at for some things, but
yeah.
Okay. Well, I have another question here. I'll tell you what, I'll give you your choice of the two, because I think we probably only have time for one more.
All right.
So here's the two questions. One is, does gabapentin increase or decrease the opiate high? And the second, am I in danger for drinking after taking ibuprofen? Your choice, or both if you want.
I think let's so let's think. So let's do the alcohol NSAID question first.
Okay.
And then if we can see if that one's too complicated to answer or not. So the specific question was, is it bad to take both? Or
here's what they said. So this morning I took 600 milligrams of ibuflam, and I think they meant ibuprofen. And approximately 3 hours later, I had my first drink at a party. I know about the dangers. I just have a hard time saying no to someone. I drank some champagne, 4 shots of some 20%. Wow, they're really getting detailed.
What time is this?
Now at midnight, I have a stomach ache.
Oh,
Online, I read it can be an indicator for intestinal bleeding. Do you guys think I'm in danger?
yeah. I'll be honest. I'm not in my 20s anymore, and after I turned 30, I get gastritis when people say scenarios that I don't want to be in, such as that one. All you had to do is throw in like some Tabasco sauce, and I would have had to pause the podcast. But yeah, I think we know that NSAIDs are damaging to your gastric mucosa. I think if that person truly meant they were taking ibuprofen, whatever they said,
Ibuflam,
even just people who don't also take, or who aren't also drinking alcohol at the same time, but just ibuprofen on an empty stomach is a setup for just some like GI irritation. We know that there's a couple different mechanisms by which NSAIDs can damage, your stomach. We know that it can not just be directly toxic, but can suppress gastric prostaglandin synthesis. It can be changes in mucosal blood flow. I mean, all of these are set up for perhaps interesting or just gastritis, right? And so even me, a old man in their 30s, when I have to take NSAIDs with my, if I take coffee in the morning with my ibuprofen, I'm going to have a bad time, right? It's not wise. And so I think if you throw on something like alcohol, it is kind of setting up, we know alcohol can be irritating as well. And if you're drinking, that sounded like they had quite a lot to drink. I make no judgments, but it sounded like that was that. Maybe is this the same person with the Jolly Rancher, or is this a different?
No.
Okay. All right. So yeah, definitely a lot. So I mean, like, I think this person may have had a GI bleed from it. I don't necessarily know their risk factors. It sounds like they may have had a bad gastritis, just by the nature of what the two things they took. So no, I don't really recommend people do the two. Could I have done it in my 20s and gotten away with it? Probably, but I don't know. So probably not the safest idea if you want to avoid some tummy aches.
Right. Tummy aches are nearly a guarantee in that scenario. So just like you said, NSAIDs, non-steroidal anti-inflammatories, they inhibit an enzyme called cyclooxygenase, which produces prostaglandins. And those prostaglandins are what tell your gut cell to secrete mucus. So you kind of start decreasing your mucus membrane in your gut that protects you from all the acidity. Now add on some alcohol and you got a recipe for gastritis. In a normal, healthy individual with no other risk factors, 600 milligrams of ibuprofen, not going to cause a GI bleed usually from a single dose. Just that more often that is a chronic issue that you develop GI bleeds from NSAIDs, unless you take a huge amount. Because when you chronically erode your mucus or get rid of your mucus, you can get into some peptic ulcers and problems that way. Really, I chose this question because I read a paper in pharmacy school, a whole paper written about this. What do you do if you have a headache after a night of drinking? Do you take an NSAID?
Oh, I love this.
Tylenol. Because, okay, is it, right? NSAIDs, like you said, they inhibit prostaglandins. Well, those prostaglandins are responsible for keeping blood flow to the kidney when you don't have enough volume. They dilate the artery that brings blood to the kidney. So when you take an NSAID, you can prevent your body from being able to deliver blood to the kidney very well. And when you're drinking, you can get dehydrated, which predisposes you to not sending enough blood to the kidney. So you take the NSAID and maybe it's, sets you up for a little bit of decreased renal blood flow. And we call it a pre-renal acute kidney injury. Or do you take the Tylenol? So Tylenol or acetaminophen and alcohol share the same metabolic pathway, CYP2E1. And CYP2E1 is actually what metabolizes Tylenol to NAPK, the toxic metabolite. This is where it all gets crazy because if the Tylenol, if CYP2E1 is occupied by alcohol, then you actually make less NAPK. So this is
why is this person a chronic use of alcohol or acute? I mean, these are the questions we want to know. Yeah. We'll message them on Reddit and ask.
Right. But that's actually what's interesting is it seems, at least in this paper I was reading, acute exposure to alcohol actually increases the rate of CYP2E1 activity non-transcriptionally. This is not induction of the enzyme, and non-allosterically. It's after the alcohol is gone, the CYP2E1 seems to work faster, which is very interesting. but it does somehow work. I'll have to find the paper. So in
Cool.
theory, if you take alcohol and Tylenol at the exact same time, you're going to make less napky. But if you take Tylenol after you've drank, I don't know how many hours, but
Interesting.
and the alcohol is gone, you might make more napky. Now, this is all theoretical. I mean, a single dose of Tylenol in a healthy individual is never going to create enough napky to harm someone. It's very safe at recommended dosages, regardless of how fast your CYP2A1 is working. Although it depends on what their glutathione stores are, I guess. But, it's all theoretical. But it's just fun to think about. There's a lot you could talk about with just this topic.
Yeah. Maybe the answer is tramadol.
Oh, my gosh. We finally found when tramadol, opioids and alcohol are always
yes, exactly.
Just kidding, listeners.
Jokes, not
as
true.
you know, none of this is medical advice. Talk to your doctor. We'll call poison center. Okay, and the only reason I brought up the gabapentin and opioid question, people are, I don't know about you, but here in Wisconsin, gabapentin is now being monitored, and pregabalin and our prescription drug monitoring, and I know 2 states, Ohio and Kentucky, actually made it scheduled because so many of their opioid overdose deaths are showing up with gabapentinoids like gabapentin or pregabalin in their blood. So I know there's animal data that shows it increases the apnea risk. It makes sense. You're combining two sedatives, but
exactly. Yeah. I always fall back on thinking about how we talk about, benzos by themselves. A big benzo overdose is usually going to be coma with normal vital signs, but then throw on something with that, such as a lot of alcohol, then I get a little bit worried about the interactions, perhaps some more respiratory depression, things like that. It's kind of the same thing. I would expect just gabapentin by itself is going to be a little bit more well tolerated. But then if you throw on anything else, like alcohol, opioids, anything, I worry that some of the effects could be magnified or compounded together, and maybe with a bad situation.
Yeah, absolutely. Oh, polypharmacy.
Can't escape it. But that's why you want to know your CYP enzymes. That's why we should all get our profiles checked. That's
true. And then we can go to Dr. Joshua Trebach's toxicology clinic, and we can get things cleared up.
Yes. We'll check your CYP2D6 today.
I'm in. Sign me up. Well, I think unfortunately that's all we have time for. I feel like we could keep going for another hour, but this has been an absolute blast. Thank you so much for joining the show today. I know, and taking your time out of moving and fellowship and everything to make time for this.
No worries.
Is there do you have any closing arguments? Any final thoughts you want to share with the listeners? Any plane?
No plane crashes. I think it's a pleasure to be here, like I said, and I think toxicology is just so much fun. I think it could sometimes look a little bit intimidating by thinking about these like big enzymes you have to memorize, or sometimes people will draw an organic chemistry structure and you're like, oh, I don't want to do that again. But I think the scary stuff is not so daunting that it should prevent people who are interested from coming into the field, because it's quite a lot of fun. We need more of us. There's not a lot of us. We need more of us. And there's always new drugs coming out. There's new pharmacology to explore. So we're always going to constantly be needed, be in business, and don't be afraid to call a poison control center near you to set up a rotation today.
Absolutely. And it's just the nicest people, as evidenced by our guest today. So
stop.
Thank you so much for joining us today. It was been an absolute pleasure. And
thank you.
Wow, Ryan, what a great guest you had on. You two really dove into some fun fish facts.
Right? We were really lucky to have Dr. Trebach join the show. What a great guest. And yes, we did cover some fishy topics.
I know some things about fish myself.
Oh, really? You've never shared that with me, Toxo. Like what?
Well, did you know the most hepatotoxic part of the fish is the minnow fin?
The minnow fin? How? I didn't know minnow fins were hepatotoxic.
Yes, acetominnow fin.
Wow, robot toxicology dad jokes. I think that'll wrap it up today. If you like what you've been listening to, go ahead and follow the show wherever you listen to podcasts so you can be aware of new episodes. And most importantly, if you really like it, give us a review. It helps us reach other listeners, and we really appreciate it. We had a great guest on today, Dr. Joshua Trebach, and he has a really fun and educational Twitter page. So if you want to do more Tox murder mysteries, go check out his Twitter at @JTrebach, And you can try to solve some of the puzzles that he has posted, if you haven't gotten enough talks already. Don't forget to follow the show on social media. We are at Lab Poison on Twitter. I am at EMPoisonFarmD. And we have an Instagram at Tox_talk, as well as a Facebook page, The Poison Lab. We'll release all of our episodes on those venues to keep you aware. And last but not least, you can always run over to www.thepoisonlab.com for all free medical games, resources, and podcast episodes. Don't forget, we'll be releasing clues for our next toxic mystery. And if you think you know what is going on, I want you to write into the show so you can take part of the next episode. Our listeners learn the most from hearing other listeners' differentials. All guesses should be sent to ToxTalk1, that's TOXTALK1, @gmail.com. Well, thanks for listening today, and I really hope you enjoyed the episode. Hope we can catch you next time. Hey, Toxo, can you play us out?
The information on this show is for educational purposes only and should not be interpreted as medical advice or treatment recommendations. Contact your doctor for health questions or call your local poison center at 1-800-222-1222. The opinions expressed on this show do not represent those of our employers. This show is poorly written and shoddily produced by Ryan Feldman. Don't forget to give it a share with your nerdy friends. See you next time. Ta for now.